Welcome to PCR Webinar dedicated to EBC Main trial. My name is Goran Stankovic. I'm interventional cardiologist from Belgrade, Serbia, and I have fantastic faculty to discuss the main implications of the EBC Main study and how we should actually approach patients with left main disease in 2022. It's pleasure and privilege to have with us Antoinette Nilon, Mary Claude Maurice, and David Hildig-Smith. David Hildig-Smith was the PI of the study, actually the most responsible one for the design and conductance of the study. And I will ask him in the beginning to share the design characteristics and the main results. I would like to ask you also, our attendees, to use the chat box and put questions, because four of us will be very happy to answer all the questions relevant to left main PCI and help you better understand how to put in the context EBC Main trial in addition to available DK Crush 5 study. So, Dave, floor is yours. Please help us understand better why EBC Main was a late-breaking trial at EuroPCR last year with simultaneous publication in European Heart Journal. Please give the slides.
Thank you very much indeed, Goran. And please don't remind me of how difficult it was to get it all simultaneously done. These are my conflicts of interest. So I'm going to talk briefly about the EBC Main study, just for about 7 or 8 minutes, just to set the scene for the webinar. So there have been many trials that have shown lack of benefit associated with systematic two-stent strategies for non-left main bifurcations, and here are some of them listed. And that was true even in patients with larger true bifurcations, where we thought, oh, maybe there is a benefit for dual stenting straight up, but actually that wasn't shown to be the case. And actually, interestingly, on the longer-term follow-up, BBC One and Nordic, who have the longest follow-up time, the outcomes are actually worse, with indeed a mortality disadvantage for those who'd had a double stent strategy. And that was a little unexpected, to be frank, but it's important data that people should take note of in the current era. So EBC Main was designed to look at similar bifurcation technology, but in the left main stem setting. So we're going to take patients with stable left main true bifurcations with vessel disease of greater than 2.75 millimeters, which were requiring angioplasty. And those were randomized either to a single stent strategy or a dual stent strategy. So the single stent strategy largely was a provisional stent approach, and this was how the study was set up. So the technical details of the study are quite important. The provisional approach is a step-by-step layered technique, which is often misunderstood. People think of it as an intention to implant one stent, but it isn't. It's a technique where you add layers, and at each stage you stop if you get a good result. So in this case, you do the stent, you do the pot, you do a KISS, which was mandated in the trial because there was disease in the side vessel. And after that, you do more if you need to. And if you don't need to, you don't do more. This contrasted with the systematic approach in which, according to operator preference, you could do T, TAP, Culotte, DK Crush. This was step-by-step according to the EBC consensus. And importantly, we wanted high-pressure ostial bifurcation dilatations and a mandated KISS plus or minus a pot. So this was very much a technique comparison between approaches and philosophies, if you like, for the left main. The study was run through Europe. We were very fortunate to have sponsorship for the study by Medtronic and all the governance arrangements that you'd expect of a study of this nature. Moving into the demographics, no big differences between the two groups. Syntax score around 22. Of course, as expected, patients in the provisional strategy had fewer stents, less stented length, less procedure duration and fluoroscopy, etc. That's to be expected. One of the key results I'd like to draw your attention to is that in the stepwise provisional approach, although the operators had obviously been happy, had the patient been so randomized, to implant 2 stents, actually when they did the provisional approach, only 1/5 of those patients actually needed that second stent. So that's a really key finding for me, that people were clearly a little surprised in the sense that they were prepared to put in 2 stents, but actually found out they didn't need to. These are the 1-year results with graphic representation. So no real difference between the 2 treatment arms in terms of death, MI, revascularization, or the individual components of the primary endpoint. So what conclusions can we draw from this study at 1 year? Well, there were numerically fewer serious adverse events with the stepwise approach. It wasn't statistically significant. Consumables, procedure time, X-ray, etc., were all less, as expected, with the provisional approach. The key for me really is this finding that only 20% of patients required a second stent in the provisional group. But that means to me that, often when people look at an angiogram, they go, oh, we're going to need 2 stents, blah, blah, blah. It's like, no, take it step by step, and you can be surprised. You don't know what you're going to need until you get there. You don't need to prejudge the issue and assume that you should start with a non-provisional 2-stent approach. Patients basically, I think, to give a nice neutral analysis of this trial, would say patients are treated equally well with a stepwise led provisional approach as with a more complex approach. And that means there are some open questions, if you like, at this stage of the EBC Main study, and there will, of course, be later presentations on it as we follow it up. Why, for example, was this quite a different outcome to the resultant DK Crush 5? Will the outcome that we've seen at 1 year change as time goes on, as we saw in the meta-analysis of EBC1 and Nordic? Why do people persist in thinking that a second stent in the provisional approach is some kind of bailout? It's not. It's a next step in the treatment if you're not completely happy after POT and KISS. And lastly and importantly, how to encourage people, especially with the guidelines the way they are, to have the resolve to start a complex case provisional and just keep adding layers until they get a good result and then stop. So thank you very much, Goran, for giving me the opportunity. And now I think we'll open it up probably for some discussion.
Yeah, thank you very much, Dave. Excellent presentation. For me, the key aspect, as you said, is that provisional does not mean single stent strategy always, because there is really frequent debate at major meetings when you mention I will do provisional as a strategy. People expect you to do simple crossover and stop after the crossover. And the second part, I think even as you mentioned in your questions, there is unclear definition. Is there really bailout in provisional defined like we do it in EBC Main? What is for you provisional and what is a bailout strategy? How it fits in the strategy used in EBC Main? Please start with that relatively the most frequent question.
Yes, I mean, the idea of bailout in provisional doesn't really make much sense. The strategy is really simple, but in some respects requires you to think on your feet. And I think that's partly why some people don't necessarily like it that much, because you do this original preparation of the main vessel, you do the stent, you do the POT, you do the KISS, and then you look at your result. Is it good? Is it good enough to leave? Are we happy? Or do we now need to put a stent in the side vessel? And if we are going to do that, what's the technique of choice? It depends on the angle, depends on your preference, depends on your experience. So your you're thinking on your feet and you're making decisions as you go. And the really key point is you don't finish the case until you think you've got a good result. So at no stage do you have a bailout phenomenon. Just as with any angioplasty, you keep going and you image and you check and you look at different projections, and if necessary, you add layers until you're happy with the result. So I think that's really got, because as you say, people have thought, oh, provisional, single stent. That's where the error is. It's not single stent. It's just, exactly. That's what we start with.
Thanks. And the second clarification, which I would like to hear from you is this study neutral, negative? There is again misinterpretation, which is also statistically not correct, that this is a negative study. Please tell us, how do you interpret the findings and the numbers we achieved?
Yeah, people have been a little bit cheeky because, the study was obviously designed on a superiority basis to give us these statistical numbers to do the study. But of course, it was pragmatic. We were never going to recruit more than 400, 500 patients. So it's fundamentally a neutral study. It's not a negative study. It's a study which shows equivalence between two important groups. And I think sometimes we take too much notice of the statistics. If you do two strategies on 250 patients and actually you don't have much to choose between them, then you don't need statistics to tell you that actually, okay, at 1 year, there turns out not to have been a great deal of clinical difference between the two strategies. That's all you need to know. You don't need to get bogged down in the minutiae of, was this a super non-inferiority study? And we get too bogged down with that sometimes.
Thank you. This is great. I would like to ask now Marie-Claude Maurice. She actually dedicated the whole professional life to promote the strategy of provisional, and Massy is the leading center. We created Bifurcation Club with team from Massy first. So Marie-Claude, your comments on left main PCI in general and on the provisional as a strategy versus planned two-stent strategy.
Thank you, Goran. But as you say, it was really a teamwork, and Thierry Lefebvre, Yves Louvard. Let's say it's really massive work. And thank you for recognizing that we were part of the pioneer as you on left main stenting and whatever. No, provisional for us, it's simple. Why make things complicated when they can be simple? Yeah, if two stents will be needed, no problem. But saying upfront that you will need two stents, for us, we consider that it was a mistake. And the reality is, years by years, evidence show. I would say, except one trial, but you cannot make laws on one trial. Yes, you must put two stents when it's needed, and only when it's needed. In PCI, the rule is always the simpler, the better, as long as you get a good result.
Thank you very much, Marie-Claude. There is one question I think fits perfectly with your comments. Ahmed is asking, thank you for the important topic, but is left main intervention always considered bifurcation? I mean, would you stent unprotected left main stent focal narrowing 50%, covering always the whole left main to LAD, or just focal stent confined to left main? So please comment, what would you do?
Again, make things simple. If you are sure that the disease is not more diffuse than you think, meaning IVUS, imaging is crucial in left main treatment. So if the disease is really focal and you can put a stent short enough not to cover your bifurcation, of course, that's simple. No need to go to the bifurcation. That's how we do in Massy, at least.
Yeah, I would like to ask now staff member of the Massy team, Antoinette Nilon, what is your current strategy and how much working with Massy team in the context of EBC Main influence current practice in 2022?
I mean, I did my fellowship in Massey, so I was indoctrinated from the very beginning in terms of this simple. It's a simple approach, but it's not at all simple. And I think Dave mentioned very well, it introduces a little bit of uncertainty, and some people are a bit uncomfortable with that. And how the decision-making process after you stent the main vessel, and what is acceptable, what is good enough, what are we happy to leave behind. And I think some of the cases we're going to show you, I think, are very informative in that, because anytime we introduce the uncertainty of will I, won't I introduce another stent, it just makes that it makes everybody a little bit uncertain. And I think it's really important as well. I'm lucky to work with a wonderful group of people, and I think particularly with left main as well, to use your peers and ask somebody. If you're not sure, if you hesitate, ask somebody. We work in a group, and that's really important. And we're extremely open with our cases and share our cases and share our experience, and that really, really helps. So if you have a doubt, just ask a colleague, and that really can help you in terms of the decision-making process. And I think simplicity, it's the ultimate sophistication. But I think to keep the basics, to follow the rules. The rules are there from the Bifurcation Club. And if you have a doubt about whether you need to go further, and it's not a bailout, it's just completing the technique to its very end. Ask a colleague, and I certainly don't ever hesitate.
Thank you very much, Antoinette, and thank you very much for helping to select cases and really share the cases from the EBC Main. And just for the colleagues, we will start by showing case randomized to plan two-stent strategy that was enrolled in the EBC Main. And if I can my slides, I would like to start with a clinical presentation of this gentleman. Procedure was done by one of our teachers, Bernard Chevalier, who actually invented the Culotte stenting, and case was randomized to two-stent strategy, but was performed with a provisional, inverted provisional Culotte. So this is my conflict of interest. And the case, gentleman 80 years old with hypertension, dyslipidemia, prior anterior MI and prior ICD, CABG 12 years before the procedure, Lima to LAD, Lima to PDA, prior stent in the circumflex, and the ejection fraction was 34%. GFR was 38 milliliters, and he presented to Massey with recurrent stable angina class 2 under medical treatment. So he underwent coronary angiogram, and these are still frames for left and right coronary artery. And because of the true distal left main bifurcation, FFR left main to LAD was performed, confirming value of 0.79, and there was tight lesion in the right coronary artery. So question is, if you look these videos, you clearly see diffuse disease in all three segments of distal left main bifurcation, rather short lesions, but truly disease of distal left main as well as both ostia of the LAD and the circumflex. And here is another projection and strategy for myself is usually provisional. According to European Bifurcation Club, we have actually classification of stenting techniques in 4 different categories, and provisional is A, stenting across. So you either stent left main across the circumflex into the LAD, or you do inverted provisional, you stent from the left main into the circ. And since patient was randomized in EBC Main to 2 stents, decision was to do inverted Culotte. Actually, all A stenting techniques, even if you stent towards the circumflex, are part of the provisional strategy. So starting stenting from the proximal left main into the distal main vessel or into the side branch is part of the provisional. And here are the steps of provisional. We don't go into many details. We already had webinars dedicated to culotte, but we predilated both branches, and after predilatation, this is the first stenting from the left main because of the plaque distribution and larger plaque burden into the circ. Also, a more angulated vessel stented first gives you more predictable course of the procedure and easier stenting towards the LAD. After the stenting towards the circ, this is the first part and always part of bifurcation PCI, proximal optimization, 4.5 by 8. And after that, wire exchange, distal strut, then opening of the struts towards the LAD. This is predilatation with 2.5, and then stenting. Stent left main towards the LAD with full overlap, and you can see also in the simulation. And next step after that is always pot. Whenever you stent, you should do pot, the same balloon, 4.5, again to achieve optimal expansion and the position of the second stent inside the left main. And after that, rewire the side branch, open the struts, sequential, as they explained, high pressure individual, balloon inflations in both limbs, and then simultaneous kissing. And after kissing, we always try in the left main when we step toward the ostium, the third and the final pot. And this is the final result in 2 projections. I think angiographically, optimal result was achieved, and we were able to perform it in a provisional fashion. We knew from the beginning, because of randomization, it will be 2-stent strategy. But I think the key message is, even if you know that you will use 2 stents, you can do it in a stepwise, logical manner, adding layers of complexity, going step by step, implanting first stent, optimizing the result, implanting second stent, optimizing the result, and doing final kissing and final pop. So there are many questions coming. If any of you would like to comment the result, maybe Mary-Claude, you wish to comment this, any suggestions how to do it better? You think we did the proper steps?
No, it was very nicely done and explained. It's typically a patient randomized in exactly the characteristic of the patient randomized in the EBC Main, and I'm sure that would it be a single stent, let's say in the provisional arm, you would have done it also well. So this is a perfect example and very well executed. And as you say, step by step, following every rule, you get very nice. You got a very, very nice result.
Thank you very much. There are some questions that I think could be addressed now. Dr. Narayanan is asking, imaging was performed only in 40% of cases. If IVUS was used more often, it would more reveal complex lesions in the side branch. Do you feel once IVUS is more often used, would it change upfront stenting strategy? I revert to Dave, but I think he already explained, even if you plan up front, you don't need to prejudge. Dave, your comment on IVUS.
Yeah, I mean, the IVUS issue has been a thorny one for EBC Main right from the start, actually. As many people will know, we actually wanted to randomize the IVUS as well to try and help us get some prospective and, unbiased information relating to IVUS, but for many logistical reasons, it wasn't possible. Although everyone says IVUS is mandatory in the left main, I think you can do left main interventions without it, as you've seen in EBC Main. And it was interesting that although it was encouraged in the protocol, actually in practice only 35% of patients had imaging. And even in DK Crush 5, it was something like 45. So there are obviously practical reasons why people end up not doing it. I mean, maybe that the IVUS machine is broken. It may be that the person you need isn't to work it isn't there. It may be that it's 4:45 and the team want to go home. I don't know. But it clearly shows that even in the setting of a randomized trial, when people know things are being counted, still the IVUS doesn't come out every time in the way that you would expect when you ask people, oh, do you do IVUS left main? Oh, yes, we always do IVUS. So there's some stuff to come out about use of IVUS, which is not yet known and understood. In general, if you do IVUS, then as long as you know what you're looking at and act on what you found, you would expect to get better results using imaging.
Yeah, thank you, Dave. I think it's time now to show two provisional cases. Antoinette will lead us through both cases, one after the other, to see what happened with cases randomized to provisional strategy. Antoinette, please take the control of the slides.
Okay. Thank you. So these are some real-life cases that were analysed in the core lab. So I'm going to show you two different types of cases. One is a case of a patient who was randomised to single stent arm. So it's a true bifurcation with the calcified distal left main stenosis, and this is a long segment disease you're going to see. So this is in the circumflex. So here you can see it's quite a calcified lesion, and you have this sort of complex distal left main calcified with this early obtuse marginal branch coming in, and quite a long segment of disease toward the circumflex. Here's another projection. So we did QCA on this, and I guess the main things to take from this are the length of disease in the side branch. So it's about 18 millimeters of disease in the side branch, which is a little bit longer than what the average side branch length was in EBC Main. From having seen a lot of the cases, a lot of the side branch disease was quite short in EBC Main, and we know that from the results. And also, significant stenosis with 60% diameter stenosis in the circumflex. So, this patient is randomized to the single stent arm. So what the operators did, so given the calcifications involved, there's rotor ablation was used. So rotor towards the LAD, and rotor ablation towards the circumflex as well. So that could come up from discussion afterwards, that if you rotor ablate the side branch, are you already changing your strategy slightly in terms of the one stent randomization? So the lesion preparation, as always, left main, it's calcified. It's critical that the lesion is well prepared before the stent is implanted, because unfortunately once the stent is there, it's a little bit too late to do these kind of things. So again, a significant obtuse marginal branch, so that's pre-dilated here with the balloon. So then to carry through the procedure, we can see stent implantation, so towards the main branch. So it, again, can be sometimes difficult for people, particularly in the left main. What is the main branch? Is it the LAD? Is it the circumflex? And of course, it depends on what your strategy is. So here we see LAD to left main stent positioning. Following the rules of the bifurcation club, we have pot being performed and wire exchange with kissing balloons. So, as we have said, it comes the time to evaluate your result and see how you've done and see is there more to do. So here we see the final result in two projections with certainly perfect flow towards the circumflex, conservation of the obtuse marginal branch, and we have the QCA at the end. So here we just see a little schema of what was done with the stent towards the left main, the pot, and the side branch, which was pre-treated with a rotor ablator and pre-dilated. And at the end, we can see from the QCA that we have 25% diameter stenosis in the circumflex at the end of the procedure with TB3 flow in all vessels. So I can go ahead. Do you want me to go ahead straight into the second one?
Let me just have one comment from Marie-Claude, because I think it's really key to understand the steps. And then you mentioned already rota in the circ, then kissing. Marie-Claude, would you do something different if it's a case outside of the EBC Main?
No, honestly, I like very much this case because it illustrates perfectly the provisional strategy. Because I think that despite the fact that we speak about provisional since years and years, I think most of the interventionalists at that moment would have done this with Twostent. And because the lesion length was long in the side branch, and it's typically a case that is considered by majority of or by many cardiologists as a case for Twostent. But this one illustrates that it can work with one stent, and if the result after the stenting, the preparation, stent implantation, pot, and kissing, if the result is good, you can stop there.
Yeah, please help us understand the proper answer from real practice. Dr. Popescu is asking, when are you happy with your results after provisional? Which is your criteria? Just as a continuation of this discussion, how do you decide when result is optimal and when you don't need second stent?
Can be, but the others can answer also. I would say residual stenosis, of course, TIMI flow. That's the beginning. TIMI flow perfect. Result residual stenosis acceptable, below 30%. No haziness, no big dissection, and that's it.
Dave, anything different? Was it predefined in the EBC Main?
It wasn't exactly predefined. It was hinted at in the protocol as to what might be reasons to continue. And those would be, as Marie-Claude suggested, a significant dissection, a reduction in TIMI flow, or a continuing stenosis, maybe a bit more than otherwise labeled, because of course you're really only looking to treat something that's physiologically significant. So it might be as much as 70%, despite the fact that it's a main vessel. But behind that, less than that, the chances of getting angina, which is the principal indication for angioplasty, are very low. So that was how we set the benchmark.
Okay. Antoinette, anything to add? Do you use same criteria or something specifically related to maybe TIMI flow or residual stenosis?
Absolutely sure that there is no problem with that the flow is normal and that you have no flow limiting dissection. That's the very basis of it. Afterwards, estimating the severity of stenosis is very difficult because often it's hard to see if it's the circumflex. It's difficult to get a good view of it, and once the stent is in place, it can be sometimes even more difficult to really see. And our eyes play tricks on us because with the MAC bands and the tones of grey, particularly around a bifurcation, we often overestimate the severity of it. So I mean, it comes back to is it physiologically important? And I think we can look to FFR and certainly go to that if we have any concerns with it. But I think if it really comes down to you absolutely, and from any of the cases that we've seen, that you must have normal flow with no flow limiting dissection. That's really important. And then afterwards it comes down to physiology and the significance of the stenosis. And I think FFR can be very useful.
Let me ask you the question of Jorge Eduardo, but the first thing would be to define if it is simple or complex to define the strategy to follow. So I think Dave already partially answered. Maybe Antoinette, you can share your perception. Do you try to define upfront if you need one stent, two stents? Are there some criteria that you are using?
Yeah, I think one of the main things comes down to it's the length of stenosis in the side branch. I think that's really important. I think you can get away with if it's very short side branch stenosis, even if it looks visually severe. With kissing balloons and with the pot and kissing balloons, you can often get a really good result. But the length is more difficult to deal with. So if you have a longer lesion in the side branch, it can be more difficult to deal with. And I think it's really important to sit down with your case beforehand and decide upfront what size stent you're going to use, what size pot balloon you're going to need, because of course that determines your stent choice for the main branch, because as we know, all stent platforms have their limits, and if you were going to need to get to 6 millimeters in the proximal part of the main branch with your pot balloon, you can't put a 3.0 stent in there. You need to plan the procedure ahead, and I like to sit down and do your little calculation and decide what size you're going to need to be in the main branch, and choose your material beforehand, and sit down with it. And it makes the case a lot easier, because then if there are unexpected events during the case, you have it clear, your strategy is clear in your head, and you can adapt much easier, much more easily. So I think it's really important.
Yeah, thank you. There are more questions on the imaging. Farman Ulak is asking, is imaging always necessary when we are doing left main bifurcation, and what to do if the facility does not have imaging? And then Piotr Pavluchuk is asking, did you always check left main with IVUS before planning strategy? I think we need a word of wisdom and Mary Claude to put point on this real life use of imaging for left main PCI.
No, I agree that it's really not an easy question, and honestly, by experience, I also changed my mind, because I think that the people that are beginning doing left main PCI, of course they should do imaging to learn, because you have complementary information from IVUS. For example, you see the size of your left main. When you do by angio, you say, okay, it's 3.5, and you would put a 3.5 stent, which is never the good size. By IVUS, we learn that left main were larger than that, 4, 5, even 5 sometimes. So IVUS help a lot, especially when you have not a very large experience, and you want to be more comfortable. And I think that of course, it has time, it has money, but the patient deserves a good result.
Yeah, thank you. I think we already have evidence from the ultimate trial, from IVUS XPL, that imaging really helps improving the outcome. We strongly recommend image use for left main PCI in all consecutive EBC consensus documents.
Yeah.
But simply for this study, we were not able to design the study based on IVUS, and I share with Dave unhappiness because we could not make this study possible at that time, maybe in the future if we need, but we definitely recommend use of imaging and lesion preparation. Antoinette, the last case is something that really helps understanding provisional as a strategy, what to do if the result at the ostium of the side branch is not optimal. So please show the last case that we selected for today.
Okay. Thanks, Goran. So here again, so this is a different type of case we're going to see. So it's a 011 lesion. It's calcified distal left main involving the ostia of both the circumflex and the LAD. And this patient was randomized to a single stent arm. So here we can see that it spares the distal body of the left main, but more towards the LAD rather than the circumflex, the plaque distribution. But again, very short lesions in both the main branch and in the side branch here. So we have some QCA here, so of it, and we can just again clearly see just very short, 5-6 millimeter side branch disease in the circumflex. So in this case, the operator stented the LAD as the main branch. So no preparation in the side branch, no preparation in the main branch. So direct stent LAD to left main. So we can already see at the ostium of the circumflex here that it's a little bit unclear as to what's going on there. So pot was performed, and then after the POT was performed, wire exchanged with side branch balloon dilatation. So there was no kissing balloons, so side branch, and this is our result in the side branch. I don't know if you want to discuss that now or...
No, I think it's clear that there is some haziness, so please proceed.
Yeah, so while the flow seems normal, it's very unclear, it's very hazy around the ostium, the circumflex. In this case, it was felt to be a suboptimal angiographic result. And because, as we've said, it is a provisional strategy, there are multiple strategies open to us in terms of how this case can be completed with 2 stents. So in this case, the operator decided to perform a tap, so a very short tap, so we can see the blocking balloon in the LAD left main and the main branch, with the side branch stent being positioned here. So we just see the second POT, which was performed, and it's always important as well in these, when we have a tap with the side branch, not to perform the last POT too close to the carina, because you don't want to undo the work that you've done with your kissing balloons. You want to keep that second POT a little bit more proximal, keeping away from the overlap with the tap. So here we can see then our final angiographic result. So we have certainly a much better result in the circumflex side branch, a wide open bifurcation we can see through both, with a good flow through both branches. And at the end here, we've just got a little diagram of our main vessel stent with a very short tap from the circumflex side branch, and overall a very good result. So this is just the use of a tap procedure to complete the case, given the suboptimal angiographic result at the ostium of the circumflex. But again, T, Culotte, it's all left open depending on the angulation and the size discrepancy as well for the main branch and side branch.
Thank you very much, Antoinette. Really great. I will come back again to our super expert, Marie-Claude, and ask the comment on this last case. But if I can summarize 3 cases, the first one was randomized to 2 stents up front, and actually provisional culotte was selected, starting stenting from left main into the circ. Second one had really long diffuse disease of the circ, calcified, even prepared with rota, but following the steps again of provisional, we achieved with kissing optimal result, and procedure was finalized with single stent, left main crossover to LAD. And the last one, with no disease in the distal left main, but isolated 2 ostia, we actually finished with 2 stents. So I think this really speaks in favor of what Dave said. You don't need to really prejudge up front. I need 2 stents. I don't need. I need 1. What is your comment on this sequence of cases that we selected today?
No, for me, that's the perfect example of the patient that we had in the EBC Main, and what the EBC Club, how they designed their trial. It's really a comparison of a systematic strategy of 2 stents to provisional one. And if you look to the 2 provisional cases that were shown by Antoinette, normally, if we judge upfront, we would have said that the first with the long lesion on the side branch would have need 2 stents, and the other one was a very short focal, very focal. Normally, they go very well with provisional and you see nothing. And in reality, it didn't go like that, because the outcome after the first step was not what we expected. But that justifies completely the provisional approach, adapt the situation to the need, adapt the treatment to the need of the patient.
Yeah, thank you very much. Dave, anything to add?
Yes.
Comments on these
Actually,
three
I just wanted to
cases.
add one thing about that. I just wanted to add something about Antoinette's last case there, because one of the things we found in the study is that, in confirmation with previous data, if you use kissing balloons with two non-compliant balloons, you have a much lower incidence, or significantly lower incidence, of side vessel dissection. And so in that particular case, it was a single balloon. I don't know if it was non-compliant, but I think for people watching, it's worth remembering that actually do remember to use non-compliant balloons for the KISS, because actually your chance of getting a dissection is less, and then it might have ended up as a single stent procedure.
Dave, can I ask you a couple of technical short questions related to our study? Muhammad Mazhar is asking, is it always mandatory to cover left main stem from the ostium with stent, or can we place proximal landing in the mid shaft? It was not pre-specified and depends on the anatomy.
Yeah, that's an interesting question. My understanding of this is that the original impetus to stent the whole left main actually also came from Massey, where there had been a couple of cases of ostial restenosis. But I think, and you, Marie-Claude, you could correct me if I'm wrong, the general consensus now is that you don't have to go all the way back to the ostium of the left main. I mean, why should you? You don't do it in the LAD. If it's subostial, you don't always go back right to the ostium, et cetera, et cetera. So I don't think the left main is any difference in that sense. You don't have to go right back to the ostium.
Yeah, thanks. Second question, again, very technical. Ganiev Alior is asking, thank you for important data. Is removing second wire from the side branch while performing POT mandatory? I think on the contrary, Dave.
No.
You don't remove the wire, you do POT.
Yeah, so the whole point of the wire in the side branch is you leave it there until you've successfully passed your new wire. And you don't successfully pass your new wire until you've done the POT. And it can be to high pressure, and you shouldn't worry too much. These wires come out, and actually, again, in contrast to what was thought some years ago, a hydrophilic wire, or a wire with some hydrophilic properties in the side vessel, will slip out easier and with a very, very low complication rate. So, that may well be the preferred option.
Thank you. I have two questions. I think Antoinette is very appropriate to answer. One question is from Sayan Narayanan. In two-stent arm, TLR was 9%. Any data on what was the reason for TLR? I know that you participated in the core lab evaluation of the angiography. So any comments on the restenosis side? There is another case question dedicated to site of the restenosis. Do we know the site of restenosis?
So it's the ostium of the circumflex that usually causes the problem. So it's, no surprises there. And it again comes down to flow dynamics and the angulation towards the circumflex. A lot of it. So you get this, slow flow because of the angulation towards the circumflex, and that that can, provoke the restenosis. So it's there where most of it was seen.
Yeah, another question I think also for you from Dr. Tung. Should we do Vstenting in the last case with isolated osteal disease? Do we still practice? I think EBC is not really in favor of SKS especially.
I mean, I think the results from Vstenting have been historically very, very poor. So, no. I mean, obviously, it's a nice idea, but, in reality, the results of it are very poor. You need to secure the carina. You need to secure the left main. It's just, it's like the ostial LAD. It comes back to the same thing. You have to cover all the plaque, and using angiography to try and position two stents at the ostia of the circumflex and LAD. It's not at all feasible. You're trying to assess a 3D structure with angiography, and it's impossible. So that's why again with like with osteal LAD lesions, unless you have very clear IVUS or OCT imaging showing you that the ostium is not involved in that the distal left main is not involved in the osteal LAD, you stent the left main. You have no other way of positioning your stent and securing and having a good result at medium term. I very much believe that.
I think one more question, really appropriate. You already discussed FFR, and Ryan Buendia is asking, would physiology-based decision-making to do either provisional, be practical in daily left main PCI practice because of the cost, low adverse events, or revascularization? Antoinette, you already discussed current use of physiology in the lesion assessment. Add some cases in which would you specifically use physiology?
Yeah, I mean, I think that if it's where you have that doubt, is this physiologically important? I use it. It's very easy to use. The wires are so performant now. They're they're extremely easy to cross the struts. And the FFR wire maybe originally was a little bit difficult to manipulate and handle, but the FFR wires are so good now that they're extremely easy to pass them into a cross stent struts into the side branch. We're actually part of Dr. Left Main, which is a trial that's looking at that as well, looking at FFR evaluation in the main branch afterwards. But I think I think it's a benefit, and we know that FFR, if anything, it prevents us from putting in stents and keeps the whole procedure even more simple, because we have an inherent tendency to the oculostenotic reflex is always there, and we overestimate it. So I mean, I think I don't know of any large scale data on it, but from any of the published FFR data, it tends to spare the number of stents rather than increase them. So I think it's very much in the same vein as the provisional doctrine. So.
Yeah, thank you. There are so many questions coming, and sorry for jumping from one area to the other. I think we should definitely repeat this webinar once again to answer all these questions. But maybe Dave, Spiridon Siamis is asking, comment about two-stent techniques in the EBC Main. Very low rate of DK crush and no DK Culotte. What is your comment on that?
I think it's because, I've talked before about the philosophy bias within the EBC Main trial and within DK Crush 5, that, you're better at and you champion the things that you really believe in. And DK Crush is not necessarily something that the European operators have particularly espoused or particularly got very proficient at. So generally, when a two-stent technique has been required, it's been a provisional culotte or provisional T or tap. So those were the majority of the cases in the study, and I think only 5% was DK Crush. And I think that was very much to be expected, really, given the premise, if you like, of the study.
Yeah, there is another similar question from Spiridon again. Maybe study to compare provisional with upfront DK Crush or DK Culotte. I think they've already answered this. You could have done Ramdeo Yadiv, you could have done DK Mini Culotte. I think the key difference between DK Culotte and Culotte is actually kiss after the first stent. And even if you don't do kiss after the first stent, crossing distal strut actually corrects this stent deformation. So it's not currently based on clinical data. It was published in neurointervention based predominantly on bench testing, and Gabor Todt published this article last year in neurointervention, and we are collecting data. Of course, we are really open-minded. We are open for any suggestions for future improvement of any bifurcation stenting technique, and I don't think we should really stick to provisional and then optimize the provisional without having possibility to improve also other strategies. There is a question regarding Is there any difference in performing TAP in culotte versus TAP stenting? So the proximal optimization at the end is not a mandatory step. It's recommended as proximal edge balloon inflation, in which you correct longitudinal deformation and you really open proximal edge of the stent. In case of TAP, especially in short left main, it's better even to avoid it, because as Antoinette has pointed, if you go too distal, you will really damage metallic neocarina and compromise good result that is achieved. And just again, maybe for Dave, were there any trifurcation left main lesions in the EBC main? Ahmed Mahmoud is asking.
I mean, there would have been some that were small, but it was a specific exclusion for any genuine trifurcations with a more than 2.75 millimeter third vessel.
Dave, maybe you can answer also this one. Piotr Pavluchek is asking, any recommendations for the side branch balloon size, 1:1 or smaller, NC or semi-compliant?
Yes, definitely non-compliant, no question about that, and 1:1.
Okay, Gianluca Tiberti is asking, I think you should point once again, let's be clear at all, when is two-stent technique needed from the beginning? I think, Dave, this is excellent question for you.
There are really only a couple of scenarios, I think, when a two-stent technique's needed right from the beginning, and that is, for me anyway, it's when I've spent half an hour trying to get into a vessel. If I spend half an hour getting into circumflex, I'm not going to jail it immediately. I'm going to secure it. So yeah, I think that's really the one main situation for me.
So difficult side branch access plus diffuse disease, I think we all agree. Marie-Claude, any comments on that one? When you plan two stents from the beginning?
No, I would have said exactly the same. It's funny because I never worked with David, but yeah, exactly the same. When it takes you a lot of time to access to the side branch. You say, okay, not do that. Let's make things corrected immediately.
Antoinette, anything to add to this?
No, I think, if
the strategy up front.
If the access is difficult or the flow is poor, maybe in a more acute setting, if it's there's alterations in flow towards the side branch, I think you need to secure it first. I mean, if you're out with the supercross and you're trying to get into the circumflex, and it's a long segment of disease, I don't think anybody would. Yeah,
there are two.
Not about making your life more complicated. Yeah,
there are two questions, Antoinette, to the case with the rota in the circ that you presented, and Christian Dan Popescu is asking, after rota in circ and predilatation of the main branch, OM branch, not need to stent, OM stenosis was more than 90%. So please repeat again your personal perspective before we conclude this session.
I mean, it's quite a particular case. Rota, it's not going to, theoretically, it's not going to damage the healthy tissue, and it's going to help the stenosis and, decalcify the circumflex lesion. Afterwards, you can see that the flow is normal in it, and you have less than, 30% residual stenosis or diameter stenosis. So I don't think that you absolutely have to. I mean, imaging, I think there would be very helpful and would make you a lot more confident in that decision also. So I think, particularly maybe in that particular case, IVUS or OCT imaging could really help you in terms of the decision making for the second stent towards the circumflex. The OM branch was ballooned. Again, it comes back to, how much of the myocardium is at jeopardy from this OM branch. I mean, it's quite a long branch. There's disease at the ostium. You're going to make the procedure procedure a lot more complicated if you are to treat that. Perhaps more aggressive balloon dilatation could be considered. But again, it comes back to how much myocardium is at risk with it. And I mean, certainly with a good result, that can always be assessed at a different stage. Is the patient going to have an adverse clinical event, or are they going to be symptomatic with angina because of the OM branch? I mean, that's something that can be seen in follow-up.
This is excellent.
We know from their follow-up for 1 year that the patient has done well and hasn't had any problems. So
Fantastic.
That's the beauty of the follow-up in a trial.
Fantastic. So I thank you all. Really fantastic session. I enjoyed very much, and I'm sorry that so many questions we did not have enough time to address, but we will repeat definitely. So thank you for contribution. Thank you to our attendees for fantastic, inspiring comments and questions. I believe that we put some light on perspective of the EBC Main in 2022. I hope we addressed major concerns regarding single stent strategy versus plain two-stent strategy, at least our position and philosophy of the European Bifurcation Club, with clear neutrality of the results of the EBC Main, which, as David said, really makes it still the default strategy for left main PCI. I thank you also to Medtronic for organizing and supporting this webinar, and I invite you all on 8th of March to discuss complications during left main PCI with Jean Fajadet, Thierry Lefebvre, and Jacek Legutko. So have a nice day, and thank you very much for contribution.
Thanks, Brian.